Good morning. Thank you very much for the warm welcome and kind words. I would like to thank also the organizing committee for inviting me to this Congress and for giving me the opportunity, if it is possible, of course, to see my PowerPoint, talk about addressing cardiovascular comorbidities in clinical practice, of course, in patients with COPD. As we all know, COPD is the third leading cause worldwide of death. And just before the COVID-19 pandemic, in 2019, we had 300 million cases globally with high rates of mortality and morbidity. And as we all know, acute exacerbation of COPD is a strong of the lungs and is characterized by sharp losses of lung function. This is a figure by Nikos Giannakis. And there are certain similarities in the catastrophic pathophysiologic cascade triggered by acute myocardial infarction or by acute exacerbation of COPD, regarding more symptoms, more hospitalizations, lower quality of life, lower exercise capacity, and finally, poorer diagnosis. And this is another diagram, again, by Professor Giannakis, a cause-effect diagram shows the different ways, the 4 different ways, in which other abnormalities may be linked with COPD. And as we all know, cardiovascular disease and COPD share common risk factors, common risk pathways, such as genes, age, smoking, etc. And among the most and clinically important comorbidities in patients with COPD, cardiovascular diseases rank first, with average rates between 40 to 50% of COPD patients. And in this coexistence, the contribution to COPD symptoms of left ventricular and diastolic diameter compared to lung function is small, but it is detectable irrespective of all other influencing factors. And this diagram shows associations between chronic comorbidity and exacerbation risk in a very large group of patients, cohort of COPD patients, and in the center we can see, heart failure, just because cardiovascular comorbidities are highly prevalent in primary care, and we all know that, and appear to be associated independently with the risk of suffering from COPD exacerbations. In this study, published in CHEST many years ago, a large group of patients, more than 25,000, were analyzed, and results suggested that exacerbation of COPD increased the risk of myocardial infarction. Actually, doubled this risk of myocardial infarction the first 5 days and returned to baseline slowly over time. This is my favorite study with a very large cohort of COPD patients, more than 200,000 COPD patients, where researchers explored temporal relationships between non-fatal cardiovascular events and COPD exacerbations, severe or moderate. First of all, the majority of COPD patients experience at least one exacerbation. Approximately 56% had moderate exacerbations, and 13% had severe exacerbations. But the most important, at the end of the study, where a total of more than 40,000 events, cardiovascular events, were recorded, was that cardiovascular event after a moderate COPD exacerbation occurred slightly later, about 14 days to 32 to 4 weeks after a COPD exacerbation when compared the time after a severe exacerbation. So the researchers encourage practitioners to act quickly by a careful specific cardiology strategy and mimic cardiologists in the month after myocardial infarction by optimization of COPD treatment and management. And this study, published in ERJ 2 years before, a very large cohort of patients without cardiovascular disease, with COPD or without COPD, were followed for about 8 years. And after adjustment for cardiovascular risk and other factors, people with a diagnosis by a physician of COPD were 25% more likely to have a major cardiovascular event. At baseline, they have not any cardiovascular disease. Okay, and this is the multi-ethnic study of atherosclerosis, MESA COPD study, where COPD patients without, again, clinical cardiovascular disease were included, and at baseline, airway wall area and percent emphysema were measured on computer tomography, whereas right and left vertical parameters were assessed on CMRI in exams 6 years apart. And here are the results. First of all, cardiac associations varied by lung structure over 6 years. And when greater emphysema was present at baseline, was associated with stable decrements in left ventricular filling and cardiac output, whereas greater wall area at enrollment was associated with increases in right ventricular mass. And this is a very interesting post-hoc analysis of impact, and the findings, the results of this study suggested the potential clinical relevance of cardiac infarction injury score and P pulmonal as risk indicators, as risk factors for adverse cardiopulmonary events. Finally, cardiovascular disease and COPD are connected with dangerous lesions, and if the mortality is the holy grail, as Professor Kostikas say, cardiovascular disease is a main cause of death in COPD in 30% of patients, mainly suffering from mild or moderate disease, because in advanced COPD itself is the main cause of death in these patients. And this is our review with Andriana and Professors Loukidis and Vasilakopoulos, and the aim was to summarize all the data we have regarding mortality risk in COPD patients and to describe treatments, pharmacological approaches that have shown effectiveness in reducing mortality. You like Dr. Vadazopoulos. Named triple therapy, triple fixed therapy, ICS LAMA-LAMA, as an early intervention. In a brief update for practicing cardiologists of GOLD document, it's highlighted that optimal management of COPD is associated with improved outcomes, cardiovascular outcomes. So the referral to specialized pulmonary care was advised, was recommended, especially if the treatment, of course, was not satisfactory. In the current document, GOLD COPD document 2025, we have a specific mention to cardiovascular diseases, including pulmonary hypertension, and a new figure regarding treatable traits in pulmonary hypertension has been introduced, where in case of COPD and severe pulmonary hypertension, an individualized treatment approach in experienced PH cedar is recommended, strongly recommended. And this is a very interesting and informative review from COPD Gold Committee regarding climate change and COPD. And this figure shows hazards associated with climate change and their impacts in people with COPD. More interestingly, in this figure from the same review, this figure shows pathophysiological responses to GOLD and to heat stress and their impact in people with COPD. GOLD is associated, for example, with bronchodissection, impaired immune defense, whereas heat with respiratory stress, increased tidal volume, increased respiratory rate, pulmonary damage, and finally, with clinical impacts in COPD, increased dyspnea and risk of pulmonary infections, respiratory failure, increased risk of cardiac events such as ischemia, arrhythmia, heart failure. Keep in mind climate change and COPD. And finally, not my last slide, but finally, what about treatment? First of all, when we have a patient with a comorbid COPD and heart failure, in a more of this group of patients receive inadequate treatment after a diagnosis, a new diagnosis for both conditions. Which treatment? Data results from the two largest randomized clinical trials regarding triple therapy, IMPACT and ETHOS, suggest a beneficial effect on mortality when compared to dual bronchodilation, LAMA. And another post-hoc analysis, this not impact from ETHOS, shows that triple therapy was associated with a benefit across a range of cardiovascular endpoints and further indicates a benefit on severe cardiovascular events. These results from this study, from this post-hoc analysis, and from other studies suggested that we could include as primary outcomes cardiovascular endpoints and cardiovascular outcomes in the big COPD trials to further investigate these things. And this is our Delphi Consensus project to capture Greek expert opinion on the position of triple therapy, why, when, and to whom, where a 3-round online Delphi survey was developed. And the final conclusion was that this consensus provided expert consensus statements on the use of triple therapy, but many of these consensus statements are not included in the COPD recommendations, although they may be used to help physicians to optimize management of COPD patients in everyday clinical practice. That's the last slide of Professor Loukidis, and this is the question from Dave Singh. Is disease stability an attainable chronic obstructive pulmonary disease treatment goal? And if the answer is yes, then we need a treatment change, probably earlier in the course of the disease, if we want to have a patient without exacerbation, without symptom worsening, without lung function decline. If we want stability, we have to make a treatment change earlier in the course of the disease. At the moment, and in the current COPD gold recommendation, a triple inhaled therapy as initial treatment, initial pharmacological treatment, is recommended only in group E with blood eosinophils at least 300 per milliliter. But based on results from big randomized clinical trials, we can hypothesize that the inhaled corticosteroids could serve as a very important treatment, very effective treatment in COPD patients suffering from cardiovascular diseases, comorbidities. So, with Kostas and Athena, we hypothesized that the use of triple therapy, ISIS LAMA-LABA, as an initial treatment in appropriately selected symptomatic and exacerbating COPD patients with a cardiovascular disease or at increased risk cardiovascular risk, could receive this effective treatment as an initial treatment. So we proposed to add a third dimension to this AB Gold COPD classification tool. Finally, and this is from Nikos Danakis again, the management and medical intervention COPD patients with comorbidities needs an holistic approach. And this is my final slide regarding helicopter study mentioned by Professor Loukidis, Hellenic Thoracic Society Initiative for COPD and Cardiovascular Diseases, regarding COPD patients, Greek COPD patients with cardiovascular comorbidities. Approximately 600 patients have been already recruited, and I would like to warmly thank Sofia Schiza, Katerina Antoniou, and their colleagues for their valuable help in this study. Thank you very much.